Dear colleagues, I'm Christoph Diener from the University of Duisburg-Essen in Germany, and in this video I will describe 5 studies. Let me start with the most exciting study, which is in mild Alzheimer's disease. We had a positive trial with an antibody against beta-amyloid at the beginning of this year, lecanemab, which is now approved in the United States. There is a second monoclonal antibody, donanemab, which was also tested in beginning Alzheimer's disease. These patients were identified by the presence of amyloid or tau protein in PET measurements. The TRAILBLAZER study randomized patients to donanemab or placebo. This was a double-blind placebo-controlled study for 18 months in 1,736 participants. In the active group, the patients received the antibody every 4 weeks IV. The primary endpoint was the Alzheimer Disease Rating Scale, and the study had 24 additional secondary endpoints. The results were impressive. The study was not only positive for the primary endpoint, but for 23 out of 24 secondary endpoints. The study also showed the already known adverse events from these monoclonal antibodies. On MRI, 24% of patients had either edema or microbleeds. And in summary, this means that at present we have 2 monoclonal antibodies against beta-amyloid, which showed efficacy in the early stages of Alzheimer's disease. Now, what this means in terms of everyday clinical practice to set up the infrastructure for the diagnosis and treatment of these patients and for follow-up, and how expensive all this will be a major problem for most healthcare systems. Now let me move to an earlier stage of the disease. The MIND trial was a trial which investigated a particular diet, a Mediterranean diet combined with DASH, which is used in the treatment of hypertension in elderly people, published in the New England Journal of Medicine. This study randomized 604 elderly patients to this special diet, which means fruits and vegetables, and avoid meat and cholesterol containing things, and the control group received just a diet with caloric restrictions. These were elderly patients who had no cognitive impairment but had a family history of Alzheimer's disease and were obese. Now, the study went for 3 years, and unfortunately, there was no difference in cognitive function across 3 years between the 2 diets. The surprising result was that both groups showed an improvement in cognitive function across 3 years, which most probably is due to the fact that including them into a study most probably led to a better treatment of concomitant diseases. But this means also that elderly patients at risk of Alzheimer's disease should have a healthy diet. Now let me move to the spinal cord. One of the most serious diseases in neurology is paraplegia or tetraplegia due to spinal cord injury. And at least from animal experiments, we know very well what are the mechanisms behind a possible repair and degeneration in these conditions. And we have biological factors, we have neurotransmitters which promote repair and axonal growth. And then we have biological factors which inhibit these repair mechanisms. And now there is a new molecule, a soluble no-go receptor Fc decoy, which blocks the inhibitors of axonal growth and improves motor function after spinal lesions in animals. And in the first time now in Lancet Neurology, this drug was given to patients with spinal cord injury, cervical spinal cord injury. The first group received the drug intrathecally as a proof of concept to show pharmacokinetics, and in the second part of the study, 24 patients were treated in a placebo-controlled design. Very importantly, this drug was well tolerated, and the levels in CSF were achieved that are needed to show a positive biological result. In the small study in patients, there was a signal towards efficacy, and now we need definitely a larger phase 2 trial to show that this new approach is effective. Now let me move to back pain. There are many approaches to the treatment of chronic low back pain, and many of them, unfortunately, are futile, and this is in particular true for treatment with drugs. The RESTORE trial in Australia had the following approach. It randomized patients with chronic low back pain into 3 arms: cognitive behavioral therapy in one group, cognitive behavioral therapy in combination with motion sensor biofeedback, and a third group with usual care. In this study published in Lancet, the primary endpoint was the Roland-Morris Disability Questionnaire at 13 weeks. 492 patients were randomized. There was a clear positive result for cognitive behavioral therapy compared with standard of care. There was no additional benefit for the motion sensor biofeedback. The downside is it's very difficult to find behavioral psychologists who can teach patients with chronic low back pain the cognitive behavioral therapy. My last study is on opioids for the treatment of acute cervical or lumbar spine pain, the OPAL study, published in Lancet. Unfortunately, many physicians still prescribe opioids for patients with acute pain in the cervical spine or lumbar pain. Now, this placebo-controlled trial was done in Australia in 347 patients with acute back or neck pain existing for less than 12 weeks. The patients in the active group received oxycodone in combination with naloxone up to a dose of 20 milligrams per day compared to placebo for 6 weeks. There was no benefit of opioids. Opioids were not effective. The patients did better in the placebo group in terms of primary and secondary outcome. And therefore, with the exception of perhaps a treatment for 2 or 3 days for extreme pain, there is no indication for opioids to treat acute pain, either low back pain or cervical pain. And this is also important because the opioid crisis in the United States showed that putting people with back pain on opioids can promote dependency. And this is something we definitely want to avoid. Dear colleagues, I'm Christoph Diener from the University of Duisburg-Essen, and these were 5 very interesting studies. Thank you much for listening and watching.